osteomyelitis and osteoradionecrosis of the jaws. Of course, those subjects not not useful for you because I'm sure that with that diagnosis, you send patient to maxillofacial surgery. But still, we could talk about that that diagnosis. So, as introduction, the osteomyelitis originates from ancient Greek, as always, as is most pathological names, right? We have osteon and myelinos. It means bone and marrow. Inflammation process of the entire bone, including the cortex and the periosteum, recognizing that the pathological process is rarely confined to the endosteum. Definition: osteomyelitis is considered as inflammatory condition of bone that usually begins as infection of the medullary cavity, rapidly involves the Haversian systems, and quickly extends to periosteum of that area. In that picture, you can see absolutely a live patient, actually. That's not the core. It's a live person. As you can see, it's very, very huge problem. It's very aggressive disease, and that make a lot of problems to patients and to doctors, as you can understand it. Predisposing factors. We have fractures due to trauma and road traffic accidents. Could be gunshot wound, it could be radiation damage, could be Paget disease, it could be osteoporosis. Osteoporosis could be provoked by some endocrinal things, right? And hormones instability. And systemic diseases. As you can see, acute leukemia, malnutrition, uncontrolled diabetes, and sickle cell anemia, and chronic alcoholism. Osteomyelitis is initiated by a contiguous focus infection and hematogenous spread, mostly, as you can understand, in children. And well, we could say that osteomyelitis of mandible is much more often, practically as a clinical cases, than osteonecrosis of maxilla. Why? There is no any strict answer for that, but still, it's just kind of statistics. Pathogenesis. Acute inflammation following infection provoke hyperemia and then capillary permeability and raise and infiltration of granulocytes. And then we have a tissue necrosis. And then we go to destruction of bacteria, vascular thrombosis, and pus forms. Intramedullary pressure rise as pus accumulates, and then we have anesthesia compression and vascular collapse, venous stasis, and ischemia. And then we have a pus accumulates with stripping of periosteum. We remember what is periosteum. Vascular supply reduced, periosteum penetration and mucosal fistulas, and chronic inflammation, granulation tissue, and lysis of bone. And most interesting thing, we have separation of necrotic bone, and we have some kind of like icebergs, like it's separated bone that moved out of the normal bone, and we call that sequestra. Shaft of the new bone. Okay. Microbiology of osteomyelitis. We understand that recognizing as disease caused primarily or osteomyelitis, it means caused primarily by absolutely normal bacteria that we have in oral cavity. All those bacteria, in normal state, we have that. So it's it's not the question of just bacteria. The osteomyelitis itself is very complex problem. There is a part of allergy, there is a part of necrosis, there is a part of infection, there's a part of inflammation. So it's a very complex thing. And as the background of all that things, it should be bad immunity status. Okay. So it's not so easy to get osteomyelitis, even if you want osteomyelitis, Abdelmohi. Not sure that you can get
Yeah.
it, okay?
Okay.
It's not so easy. Okay. Um, yeah, there is some classification of osteomyelitis. We have separative and we have not separative. Two classification of osteomyelitis. Acute, secondary chronic, and primary chronic osteomyelitis. I should say that there is a few, really, it's a few classification, and we use classification that we distinguish that on acute osteomyelitis, on like subacute osteomyelitis and chronic osteomyelitis. And fourth one is a chronic osteomyelitis that becomes acute again, like reacuted. I don't know how to explain that. That's very hard. Imaging techniques. Of course, to put that diagnosis, we need to do some diagnostical things. Okay, so one of them is imaging techniques. It could be conventional radiographs. It could be radionuclide imaging, or it calls, not sure how they pronounce that, scintigraphy, perhaps, and computed tomography, very common, and magnetic resonance imaging. Magnetic resonance imaging we use when we understand that there is a lot of soft tissues damaged. Uh, uh, Additionally to the bone damage, of course, because primary, the problem is in the bone. Conventional radiograph, um, moth-eaten appearance, enlargement of medullary spaces, destruction and replacement with granulation tissue. Here on the lower picture, you can see the that we call sequestra. So it's separated bone island. Let it be island, okay? Just don't know how to explain that. Oh yeah, island. There is island okay. There's island
It's
sequestra
look like
with
an island. Yeah.
I didn't see that word, sorry. Okay, see, I'm not lying. Island sequestra with evidence of trabecular patterns and moral spaces. A shaft of the new bone often is found separated from sequestra by the bone of radiolucency. Yeah, the radiograph is very useful when we talk about chronic osteomyelitis. Because if you have acute osteomyelitis, I mean, till 7th day, let it be, you're not gonna see anything on the X-ray, on radiograph, and computer tomography. So it's not informative. And after 2 weeks, yeah, we could see some changes. Computed tomography. As you can see here, we have a bone destruction, very obvious bone destruction on the upper picture, even with destruction of lamina compacta, as you can see here. And of course, we have a problem with periosteum, and of course, we could problem with some soft tissues around that. And on the lower picture, you can see the example of scintigraphy. It also informative, but mostly it used perhaps additionally to some X-ray examination. Okay, so we switch to acute suppurative osteomyelitis. Characterized or acute osteomyelitis by, and you can see that deep intense pain, high intermittent fever, crestasia of the lower lip, and we call that Vincent symptom, or Vincent maybe in English, right? The Vincent symptom is a paresthesia of the half of the lower lip. Okay, a clearly identifiable cause and minimal swelling and fistula are not present. Fistulas is the things that we could see only in chronic process. On imaging, we doing as you wish conventional radiographs, not too much use. As I said, you're not gonna see anything. And radionuclide scan could be positive, but still, if you have that in your hospital, if you have acute pulpitis, you're not gonna see anything on X-ray. If you have acute periodontitis, you're not gonna see anything on X-ray. If you have acute peristitis, nothing. Acute osteomyelitis, nothing. Because any acute inflammatory disease, inflammatory process is just pathophysiological things in soft tissues. As you remember, alteration, infiltration, proliferation. And on the stages of proliferation, it goes to chronic way. So when you have a chronic pulpitis, you can see something on X-ray. Chronic periodontitis, you can see something on X-ray. Chronic periosteitis. We describe 3 chronic periosteitis here. Not sure in your place. And all 3 you can see on X-rays, but 0 acute. And chronic osteomyelitis as osteonecrosis. You could see that on X-ray. So please do not do additional imaging if you have acute process, any acute process. You're not going to see anything on X-ray. Okay, finally. Laboratory investigation. We could use something, of course, like blood analysis and others. It depends on the stage of the osteomyelitis. So till nothing, not that, from nothing till some leukocytosis. I mean, you cannot put the diagnosis just using some one sign, you know? To put that diagnosis, any diagnosis, you need to gather all the things that you have, you know, including imagination, including blood tests, including some microbiological things, including what? Including what you see and others. So you need to gather it all together. That's how you put the diagnosis. Just bacteria things is not enough. I mean, bacteria, we have a lot of bacteria inside or outside on us, and we are okay. Yeah. But still, if you have that immunocompromising condition, like as I said, like background of bad immunity, you need to work with that. So if you just put antibiotics, that's it, that's not a treatment. That's just covering, you know, you just cover it. That's not treatment. You need to find a real reason for that. Real reason is not just bacteria. Real reason is a lot of factors that come together, that came together. And that we have that diagnosis, the osteomyelitis. As I said, that's not so easy to get osteomyelitis, even if you really, really want it. So subacute is not acute anymore and not chronic yet. Okay. So as you can see that from 10 from 10 to 14 days after onset of acute suppurative osteomyelitis, and we have some clinical features like as a deep pain, malaise, fever, and anorexia. Teeth begin to loosen, nice. Pus exudes around the gingival sulcus and through the mucosal. We have, not we, the patient has fetid odor, firm cellulitis of the cheek, and expansion of the bone from increased periosteal activity. Abscess formation, nice. Trismus is not always present. See, that's why we need to use the Burchett as Yasin. Very useful. If some patient with subacute suppurative osteomyelitis will come in your dental office, now you know what to do. And regional lymphadenopathy. The patient's temperature may reach 37 degree, even 38, but it depends on the organism, and the patient often is dehydrated. Okay, not very good, but still. And then we could move to chronic osteomyelitis. We have two subtypes. We have primary and secondary. In secondary chronic osteomyelitis, the type observed in a completely treated acute osteomyelitis, the clinical findings usually are limited to fistulas. Remember, what is that? Induration of soft tissues and the thickening of wooden character to the affected area with pain and tenderness on palpation. Conventional radiographs. As I said many times, if we have chronic process, we could see on the X-rays or radiographs or any imaging testing, we could see a huge changes, except bone changes. As you can see, full extent of bone dissolution. We could see that on third week. And see, just a lot of percentage of bone destruction. That's really sad, actually, and not good for patient and not good for us because we need to deal with that and do some bone restoration and reconstruction of the bone. And of course, even if we do that reconstruction, there is no guarantee that everything gonna be okay after, like in 2 years. If you now work with immunity and allergic component, there could be, as I said, it should, I don't understand why there is no words about allergic component, but in osteomyelitis, what is distinguish it from others diagnoses? There is an allergic component. Absolutely 100%. So if you're not gonna work with that allergic component and immunity status, you're gonna have that disease again. Scintigraphy imaging, as you can see here, computed tomography, as you asked before, perhaps you ask about computed tomography. Yeah, we can use that, and magnetic resonance imaging if we interested in soft tissues, we could use that too. Okay, treatment modalities. As you can see here, first, evaluation and correction of host defenses, gram staining and culture and sensitivity testing. Sensitivity testing, finally they do something with that. So sensitivity testing is an allergic component that I try to explain you. Imaging to rule out the bone tumors empirical administration of Gram-stain guided antibiotics, removal of loose teeth and sequestra, of course, is necessary. Prescription of culture-guided antibiotic therapy, repeated cultures, possible placement of irrigation drains and antibiotic beds, and sequestrectomy, debridement, decortication, and reconstruction, as I told you before. A huge problem, actually, a huge problem, as I said, for not for students, for patient and for doctors. Yeah, we have a conservative management and we have surgical management. Conservative management mostly for acute osteomyelitis, and surgical, of course, mostly for chronic osteomyelitis. Blood transfusion, control of pain, the rehydration, of course, nutritional support, of course, surgical, of course, hyperbaric oxygen therapy. Yeah, nice. Extraction of offending teeth, incision and drainage, sequestrectomy, catheterization, decortication, resection, reconstruction, post-operative care. It's a surgical management. What about conservative management? Of course, most of that treatment is dedicated to antibiotics. We have three regimes. If you can see here, it could be penicillin or clindamycin. I really like clindamycin, actually, and it could be any of them. What I would ask you is just remember that all antibiotics that you use in a case of osteomyelitis, actually in the case of any odontogenous inflammatory process, so that as you can remember, the genus means the source of infection is in a tooth. And of course, we have a problem with bone because there is a connection. So they should be friendly to bone. So, okay, the main thing, it's that antibiotics could go to the bone and could accumulate in bone. Not any antibiotics could do that. So what we use in dentistry, in stomatology, and maxillofacial surgery, in oral surgery, we use the antibiotics that could penetrate into bone and accumulate there. Closed wound, irrigation, suction, of course, we need to irrigate it with some solutions. It should be, of course, again, with antibiotics or just on antiseptic solutions, impregnated breads. Okay, perhaps, but not necessary. Yeah, here, hyperbaric oxygen therapy. See, that's how it looks. So the patient is inside some capsule, and there's a interesting technique of inhalation, as you can see, of 100% humidified oxygen under pressure. Sweet, right? Very interesting. Sequestrectomy, you can see how it looks, and on the upper picture is exactly the sequester. Catheterization, okay. Decortication, okay. Resection, reconstruction, okay. That is a subject of fifth year. I mean, reconstruction of the bone. So clinical findings, yeah. It's osteomyelitis. It's very bad thing because if you see osteomyelitis in nouveau-né, it means very bad
Newborn.
sign.
Right.
it's bad sign. It means that it's some huge problems with immunity, like
Mm.
leukemia and all those things. Not good. Not good. Unfortunately. Non-suppurative osteomyelitis, blah blah blah, chronic focal sclerosis. Okay. Actinomycotic osteomyelitis, yeah, it exists. Not good. Tuberculosis osteomyelitis exists. Not good. Osteonecrosis, not good. See, it's non-healing wound caused by hypoxia, hypocellularity, and hypovascularity. I mean, okay, as summary, let me say that of course I understand that it's far from your practice, but still, if you're doing some fillings, some prosthetic things, some orthodontic things, some
Protocol.
other things, and you see something that is not okay, some ulcers, some wounds, some injuries, some not typical things, some very strange things, please do something. At least give that information to patient. At
Yes,
least
of course.
uh, give that information, just move patient to that thinking
Yeah,
that
yeah.
he need to do something with that. Some
Mm.
additional examinations, some additional maybe it needs to see that dermatologist or ophthalmologist or other doctors. Just do something, not just
Yeah.
close your eyes. Okay, I'm doing just fillings and that's it.
I'm half
Go
blind.
home. You know,
Yeah.
that's what I ask from you.